ECGs, or electrocardiograms. Are they incomprehensible squiggles on a piece of paper? Or are they diagnostic, real-time health status indicator information about your patient's most vital organ? My name is Ryan Feldman. I'm an emergency medicine pharmacist and clinical toxicologist. I frequently find myself having to educate my pharmacy learners on what the different leads of a 12 lead represent and what the different waveforms of an ECG tracing can represent. Now, the name of this lecture is ABCs of ECGs for PharmDs because that's who I most frequently teach this to. But this is designed for really anyone who wants to be able to take those incomprehensible squiggles and turn them into valuable information about the patient in front of them. We're going to learn a basic process for ECG interpretation, and built into this lecture, there's actually a study guide that you can fill out alongside it, and we'll have real-time practice problems that we do during the lecture and review the answers during. So, if you've got some spare time, follow along with us and turn those incomprehensible squiggles into real information that you can use to help your patients. You'll find the study guide in a Google Doc link in the description of this video. The table of contents are listed here. We're going to review everything from how the body generates a signal an ECG can detect to what an ECG measures, what the different waveforms that an ECG tracing produces represent, how to label them, and where the different leads of an ECG measure those waveforms from. Finally, we'll learn a 5-step process for reviewing ECGs: rate, rhythm, axis, hypertrophy, and ischemia. The goal is to be able to objectively identify abnormalities. And finally, once we've objectively identified anything out of normal, putting the pieces together to interpret what the ECG represents. The table of contents are listed here with timestamps where each of the sections start. I always recommend a good review of physiology to understand what it is that we're actually measuring. But based off your learning level, feel free to jump around to what you think will be the most valuable. Without further ado, let's get started. The cell is the basic fundamental unit of life. I know this is very basic, but stay with me because I think it's important. These little buggers are what allow us to react to external stimuli and adapt to change, as opposed to just being a pile of chemicals diffusing into the rapidly expanding universe. See, we're basically a lot of water with solute dissolved in us. And normally, when solute dissolves, it expands outward. Let's take an example of sodium chloride. Here we have a sodium chloride crystal. It's dissolving, meaning that the individual sodium and chloride is getting dissolved by the solvent water. And once it's fully dissolved, those particles spread out and diffuse as far away from other particles as they can to increase states of disorder. This is called entropy. But there's really no rhyme or reason into where these particles concentrate. They will actually be equally distributed throughout the solution. Yet, when you introduce life to this scenario, we can actually concentrate those ions into compartments. Yes, they'll spread out randomly within those compartments following the rules of entropy, but we can keep all of our, say, potassium on one side of a compartment and other ions on the other side. And this sets up the conditions that allow us to change and adapt according to external stimuli. So, what makes us different than the non-living universe? How are we able to concentrate these ions into specific compartments? And why does that matter? Each cell is composed of a cell membrane made up of hydrophobic nonpolar heads and these fatty acid tails. This is called a phospholipid bilayer. These hydrophobic nonpolar heads keep charged molecules like hydrophilic polarized ions, such as sodium or potassium, which are dissolved in solution, from entering into the cell. The only way for these ions to enter the cell, due to them being repelled by our cell membrane, is via active transport, via probably the most important pump in your entire body, the sodium-potassium ATPase pump, where we spend hard-earned energy, or ATP, on actively transporting potassium into the cell for an exchange of taking sodium out of the cell. Now, this doesn't happen in a 1-to-1 ratio, and that is extremely important for life. Potassium is pumped into the cell at a ratio of 2 potassium in for every 3 sodium that are pumped out of the cell. It doesn't take a lot of math to realize that's 1 extra positive charge being pumped out of the cell. If we carry this out, we can see that there's going to be more positive charges outside the cell than inside the cell. The relatively fewer positive charges in the cell makes it more negative compared to outside. If we were to actually stick an electrode through the cell membrane and measure the difference in charges between the inside and outside of the cell, we would see that the potential difference is roughly -70 millivolts. This is called a transmembrane potential, or what we call the resting membrane potential, the difference in charges at rest in a normal cell due to the activity of sodium-potassium ATPase pumps pumping more positive charges out of the cell, and the phospholipid bilayer allowing these charges to stay in their concentrated compartment by preventing them from diffusing back across the membrane. So we could see that the cell is negative, and if you're negative, that would mean you're polarized. And if you're polarized, that means you can depolarize. And this ability to depolarize allows us to send signals intracellularly to initiate all sorts of processes in response to stimuli, allowing us to react to our external environment. It is an incredibly important part of physiology. Heart cells depolarize to initiate a sequence that leads to cardiac contraction. Depolarization occurs when the sodium channels on a myocyte, we'll talk about what those are, open up and sodium follows its concentration gradient into the cell, leading to more positive charges entering the cell and going from my resting membrane potential of around -90 or whatever I'm sitting at, positive charges flood into the cell and I actually depolarize up to about +50 millivolts. As we said, the entire purpose of depolarization is to activate the cellular machinery that leads to some sort of response to a stimulus. In this case, depolarization of a cardiac cell with sodium is to open up our voltage-gated calcium channels. So sodium floods into the cell. Calcium then is able to enter the cell through voltage-gated calcium channels. As calcium is entering the cell, I have positive charges entering. All the potassium that was inside the cell and was being held in via the net negative charge, remember potassium's positive and the cell was negatively charged via its resting membrane potential, well now the cell is positively charged. So potassium follows its concentration gradient leaving the cell. So I have potassium leaving, which is positively charged leaving, and calcium entering, positively charged entering. So positive out, positive in, I sit at a net neutral in terms of my current. There is no net flow of charges in or out. As calcium enters the cell, it moves to the sarcoplasmic reticulum and binds to something called a ryanodine receptor. The ryanodine receptor releases intrasarcoplasmic reticular stores of calcium, which come out and bind to a molecule on top of actin, which is called tropomyosin, and this releases the active actin binding site. Actin then binds with myosin, you get cross-bridge formation, and you contract a single cardiac cell. This is called excitation-contraction coupling, and it's the whole purpose of cardiac depolarization. After all of this is complete, the calcium channels shut off, the sodium channels are inactive, and potassium continues to leave the cell following its concentration gradient, no longer being held in by the negative charge of the cell, and this leads to repolarization, at which point my ion concentration gradients are reestablished via my vitally important sodium-potassium ATPase pump, pumping out 3 sodium for every 2 potassium coming in. That is your review of the cardiac action potential in the basic physiologic electrochemical gradients that allow for us to sustain life. Now there are 2 types of cells that compose the heart, pacemaker cells and myocytes. Pacemaker cells are what we call automatic tissue because they automatically depolarize. They have a special type of sodium channel on them called a funny type sodium channel that's always open. It allows sodium to slowly enter the cell following its concentration gradient until it reaches a threshold potential, at which point it fires off an action potential through the heart. They're non-contractile cells. They do no squeezing. All they do is spread depolarization through the heart. You can see the network here. It starts with the sinoatrial node, moves through the atria to the atrioventricular node, where it then gets conducted to the bundle of His, and then splits off into the Purkinje fibers, which spread the depolarizing wave through the ventricles. Myocytes do the squeezing. Muscle doesn't have a lot of brain, so these guys need a stimulus, generally propagated from the automatic tissue. Now these myocytes are connected by gap junctions to other myocytes. So when it feels a depolarizing stimulus come through, it can conduct it to all of the cells around it, which is great. Think about it like a pebble being dropped into a lake. It'll spread the depolarizing wave in ripples outward around it in all directions as opposed to linearly. Understanding the sequence of depolarization in the heart is very important. Depolarization begins in the sinoatrial node, where automatic tissue depolarize and spread that depolarizing wave to the myocytes of the atria. The atria will then depolarize, and that wave finds its way to the atrioventricular node here. From the AV node, the depolarizing stimulus spreads down through something called the bundle of His, and then to the Purkinje fibers, which are fibers that encase the ventricles and allow the depolarizing wave to start from the bottom up of the ventricles. So the order of depolarization is the sinoatrial node, then atrial depolarization, atrioventricular node depolarization, which spreads to the bundle of His and Purkinje fibers, and then finally we get ventricular depolarization, which leads to ventricular contraction. So what exactly does an electrocardiogram, or ECG, measure? Well, we just discussed that cardiac depolarization is the movement of ions across a membrane, and the movement of ions is current, and current generates force. Now here's something to consider about force. You're driving 60 miles an hour to the west. You fire a soccer ball 60 miles an hour east. Which way does it go? Well, as you can see, it drops straight down because the total force vector is equal to the sum of all forces acting on it. When we consider the heart, the largest side of the heart is the left side, and the ventricle is the largest portion. So the left ventricle, which is on the bottom left part of the heart, is the largest tissue area of the heart, meaning it has the most muscle. More muscles means more ion, means more current. So more current equals more force. And if you measure the total overall force vector of the heart, you can detect a force moving downward and to the left, because the right ventricle is generating some counter force, but the overall net detected force is moving downward and to the left. As a kid, did you ever try to take two positively charged sides of a magnet and press them towards each other? Well, they repel. This is essentially how an ECG works. Here, I have a positively charged electrode, and it will be deflected by a positively charged force moving towards it. Here I have the sinoatrial node sending a depolarizing stimulus to the atria. The atria depolarize. Ions move across membranes. Current which generates force. Force which is moving overall downward and to the left towards my electrode, which then deflects the electrode upward, creating the morphology of a P wave from atrial depolarization. It then falls back down to its isoelectro point after the depolarizing current has stopped. This is going to be an incredibly important concept when we talk about lead placement and why different leads create different QRS morphologies. as well as when we talk about a concept called access later in the lecture. So an ECG measures voltage, or the electromotive force of the heart, where when current moving towards a positively charged lead leads to a positive deflection. Thus, the y-axis is voltage and x-axis is time. And the more current involved in the deflection, the higher the voltage that is measured. Here is a typical ECG tracing of a heartbeat. I've labeled all the segments, and we're going to define what they are based off their morphology, and not necessarily what they represent. And there's a reason for that. So let's go through it first, and then I'll show you the reason. Here we have the P wave, which is the first wave prior to an RS wave. We have a Q wave, which is the first downstroke that occurs after a P wave. The R wave is defined as the first upstroke after a P wave, and the S wave is defined as the first downstroke after an R wave. Finally, we have the T wave, which is the first up wave after an S wave. Why am I defining them like this? Let's take a look at a few ECGs. As you can see, you won't always have a perfect PQRST. So it's good to know that once you find the P wave, the R wave is going to be the first thing that goes up after the P. For example, here's a P wave. Our R wave is right here, and there actually is no Q wave. So if we remember, the R wave is the first upstroke afterwards, it's easier to identify. After the R wave comes an S wave, and then the first upstroke after an S wave is our T. So I want you to focus on being able to identify these waves, and then we'll talk about what they actually mean. P, Q as a downstroke, R, S, T. How about up here? What are all these squiggles? This is called artifact, and it's very frequently seen when taking ECGs in real life. It's from a patient moving around in the middle of getting an ECG. But let's try to label this ECG pattern. We potentially have a P wave here, or maybe there. We have an R, S, a T might be somewhere on here, and P, R, S, T, P, R, S, T. And you can see here, this R barely goes upward, but that would be our first upstroke, and that's why we call it an R wave. Take a minute and practice labeling the waves on these two rhythms. When you're done, go to the next slide. Now that we can identify the intervals, let's define what they actually mean. The P wave represents atrial depolarization. The Qrs interval, or sometimes just the Rs interval, since Qs are not always present, represents ventricular depolarization. And then the T wave represents ventricular repolarization. The reason we don't see atrial repolarization is it is hidden within the ventricular depolarization wave. Intervals to know about would be the PR interval. This is the length of time it takes for the atria depolarization to depolarize the ventricles. If this is prolonged, it can sometimes mean that there is a heart block, or a block between the atria depolarizing the ventricles. The QRS interval is the time it takes to fully depolarize your ventricles. And if the QRS is prolonged, this can mean something is causing it to take longer to depolarize your ventricles. And we will talk about what kind of things can cause that. Finally, we have the ST interval. This represents the end of ventricular depolarization to the beginning of repolarization. And the QT interval. This is also known as the pharmacist's interval. Remember, repolarization occurs from potassium leaving the cell. Drugs that block potassium leaving the cell prolong the QT interval because they prolong ventricular repolarization. This predicts the likelihood of entering into a rhythm called torsades, and drugs that prolong the QT can increase your risk of torsades. So many pharmacists are charged with identifying drugs that might prolong the QT interval. Now that we know the morphology of an ECG and what each of those waves represent, as well as those intervals, let's figure out how to measure them. The ECG grid is set up in boxes. One large box is 200 milliseconds, so 5 boxes is equal to 1 second. In each large box, we have smaller boxes. It's 5 by 5. So it's 200 milliseconds long, and there's 5 small boxes within there, which means each small box is 40 milliseconds, 200 divided by 5. We can measure the intervals of an ECG, and it's very important to understand what a normal interval is, which is why I've left them out of this lecture, so you'll write them down when we actually go through it. Let's measure the PR interval in this patient. 1, 2, 3, 4 small boxes is what we counted. 4 times 40 is 160 milliseconds. A normal PR interval is less than 200 milliseconds, so this is normal. Now let's measure their QRS complex. 1, 2. There's the end of the S. That's 2 small boxes or 80 milliseconds. A normal QRS complex is less than 120 milliseconds. Let's measure their QT interval now. Start at the Q. 1, 2, 3, 4, 5, 6, 7, 8, 9. Maybe 9? Maybe into 10? 9 times 40 is 360 milliseconds. A normal QT interval is less than 400 milliseconds. However, as the heart rate speeds up, this shrinks down. Because we're going faster and faster, we repolarize quicker. So to correct the QT interval for the shrinkage that can occur at a high heart rate, we do something called a corrected QT interval. There's many different equations you can use to correct. Framingham's and Bazette's are some of the most common, but you'll be able to read the QTC at the top of an ECG. The computer will do the calculation for you. A normal QTC is less than 440 in men or less than 460 in women. All right, pause the video here and answer these questions as a knowledge check. I want to make sure you have a good understanding of what the ECG actually means before we move into interpreting them. Pause it now, and when you're ready, press play and I'll review the answers. Here's an ECG tracing with the different wave morphologies and what they represent. The P wave is atrial depolarization. A PR interval, being normal, would be less than 200 milliseconds. That's the time it takes for the atria to send a depolarizing stimulus to the ventricles. Having a long time between a P and a QRS means there's some delay between atrial depolarization and ventricular depolarization. Frequently, this is an AV block. A QRS wave represents the time of ventricular depolarization. A long QRS would represent something delaying ventricular depolarization, either channel blockade or not appropriately depolarizing both ventricles at the same time. We'll talk about different causes of long QRS. Finally, the T wave represents ventricular repolarization. To have a long T interval means you have a long repolarization phase. A long QT interval could be caused either by a long QRS wave or by a long T wave. Having prolonged ventricular repolarization puts you at risk of torsades. All right, time to jump in to lead placement and interpreting ECGs. Here we have a standard 12-lead ECG. They're a little bit confusing to look at, so I'm going to walk through it with you. The x-axis is time. The ECG machine automatically changes leads as it's reading over time. So we have 3 total rows, and each row switches through 4 leads over time, giving us a total of 12 leads to read from. In the beginning, this is the first heartbeat, and it's the same heartbeat as this one, which is being read from lead 2, and this one, which is being read from lead 3. The morphologies look different because the electrical activity is being picked up from a different lead perspective. Then we have our second heartbeat, third heartbeat, fourth, fifth, it looks like the ECG machine switches leads here into AVR, and on this row it switches to AVL and AVF. But these are all the same heartbeat, just being measured from a different electrical angle. Finally, this last row is lead 2, and it's just a continuous reading of all the heartbeats from a single lead. Now, why do all of the ECG leads display a different morphology? Each lead is actually detecting the heart's electrical signal from a different perspective. They're like stationary cameras that can see the heart from one viewpoint only. Think about it like an Instagram influencer sitting in a room. They're not moving, but the camera angles are changing to get a complete view of the person. Each lead picks up the electrical activity based off of its position and develops a different waveform based off of the electrical activity it's detecting. You need to look in each lead in order to see a full and complete picture of the heart. There are a total of 12 leads, 6 limb leads and 6 chest leads. We're going to talk first about the limb leads. The limb leads look at the heart from the lateral and inferior sides, and they have the perspective of looking at a clock from the side, as if you were looking down the minute or hour hand of a clock. You can't see the face of the clock, but you can look down the side at it. The names of the leads are 1, 2, 3, AVL, AVF, and AVR, and I'll explain the perspective that each of them has. Let's talk briefly about what a lead actually is. It is simply a reference point from which to graph the electrical depolarization current of the heart. In the original ECG, they placed electrodes on the right arm, right leg, and left leg. The right leg acted as a ground, and the rest of these had charges, positive and negative charges on the electrode. Using data from the negative charge on the right arm and the positive charge on the left arm, they generated lead 1. This is called a dipolar lead because it uses data from 2 points. The negative charge is the reference, and the positive charge is actually exploring the electrical current of the heart. Remember, when positive charge moves towards another positive charge, it creates an upward deflection. Since the positive charge of lead 1 is on the left arm, it is sitting right in front of the charge moving towards it, and it will deflect positively when it detects current moving towards it. Other dipolar leads include lead 2 and lead 3. Lead 2 is made from taking the negative charge of the right arm and drawing it to the positive charge of the left leg. And since this is downward, and we know that the overall net force of depolarization is downward and to the left, we know that anything that is positioned downward and to the left should deflect upward when it detects force. So this is detecting force. Here's lead 2, and you can see the angle from which it's detecting force here, and this deflects positively upward. Lead 3 is another dipolar lead, getting 2 inputs, and this is actually from the negative charge on the left arm to the positive charge on the left leg, and this also deflects upward, detecting force a little bit more rightward, but still inferior from the bottom, detecting the overall net force moving downward. Then we have the augmented voltage leads. These are unipolar leads, detecting only from the positive charge of one of the electrodes. AVF, I think of as augmented voltage foot, because it's detecting the positive charge from the vantage point of the foot, which is directly perpendicular to the heart and is a direct inferior reading of the heart. AVL has the vantage point of detecting from the left arm, but without the balancing charge of this negative charge on the right arm, it is detecting slightly more elevated than the heart. So we get this negative 30-degree upward deflection of where we're detecting from. This is still generally upright as it's located on the left side of this axis, so it's detecting the total net depolarization to the left, but this is AVL. And finally we have AVR. AVR is using the positive charge on the right arm. And as we know, the net depolarization is downward and to the left. So all depolarization is moving away from AVR. Thus, the morphology of AVR is essentially inverted to anything on the left side. And we'll see a downward QRS, frequently upside down P and T waves. This is a nice map of where the leads are actually detecting the force of depolarization. And we can use these as a reference for what we should expect the morphology to look like. So here's another map of the limb leads, a little bit easier to understand. We have our left placed leads, which is lead 1 from the left arm combined with inputs from the right arm, and lead AVL from the left arm alone. These are on the left side, and we call them our lateral leads. So lead 1 and AVL are lateral, detecting input from the left side. Then we have lead 2, lead AVF, and lead 3, which are our inferior leads, detecting input from the bottom of the heart. And finally, we have our reciprocal lead, AVR. The tracing does the opposite of lateral leads. It's watching the current march away. So lateral leads are watching the current march towards them. AVR should be the reciprocal of whatever you're seeing in 1 and AVL. Let's stop here and do a knowledge check. Pause the video and answer the questions. When you're done, press play and we'll go over the answers. If there's signs of ischemia in lead 2, 3, and AVF, these are inferior leads. Thus, there's likely ischemia occurring on the inferior portion of the heart. If ischemia would be occurring in lead 1 and AVL, those are our lateral leads, and thus we might expect lateral ischemia. So whatever vessels supply the lateral side of the heart might need to be targeted by the interventional cardiologist. If the QRS is upright in 1 and AVL, which are lateral and having current march towards them, then it should be upside down in AVR, which is watching the current march away. As a practice, fill in each one of these vectors with the lead that is detecting current from that angle. When you're done, press play and we can go through the answers. Lead 1 is directed directly lateral to the heart and is detecting this current. This would be lead 2, slightly downward and to the left. AVF is directly inferior. We have lead 3, which is slightly rightward but downward. AVR, which is almost behind the heart, and AVL, which is slightly upward but to the left. Now we're going to talk about chest lead placement. These are unipolar leads, meaning they detect only from one angle, so we don't have to worry about force vectors anymore, and they're much easier to understand. Here's the placement: V1, V2, V3, V4, V5, and V6. V1 is positioned near the right atria and right ventricle. So much like AVR, it's seeing a lot of force march away from it. Thus, it's frequently downward for its QRS morphology. V2 is thought to look at the right ventricle, and V3 looks at the right ventricular septum. This is called a septal lead. Finally, we have the left side of the heart. V4 looks at the left ventricular septum, V5 at the left ventricle, and V6 at the apex of the left ventricle. These also let us look anteriorly at the heart. Remember, the limb leads only let us look from a top-down perspective, or looking down the hand of a clock. These let us look right at the clock face. And we have V1 through 3, which look at the right side of the heart, and V4 through 6, which look at the left side of the heart. Here's a summary of your 12-lead placement and the different vectors that they can detect the force of depolarization from. Our lateral leads are lead 1 and 2, V5 and V6. Our right side of the heart, anteriorly, V1, which is right ventricle and right atrium, and V2, which is right ventricle. Our septal leads, V3, which is RV, septum, V4, which is left ventricular septum. Our inferior leads, 2, 3, and AVF, and our reciprocal lead, AVR, hanging out way over here. Let's do a knowledge check. Pause here and answer the questions. When you're done, hit resume and we'll go over the answers. Which leads look at the anterior portion of the heart? The chest leads or the limb leads? Remember, V leads or chest leads are placed directly anterior, thus they can measure the anterior portion of the heart. Limb leads only see the heart as if you were looking down the minute hand on a clock. If there are signs of ischemia on 1, 2, and AVF, which is a lateral and inferior lead, and V1 and V2, where's the ischemia occurring? Well, V1 and V2 are right side of the heart. AVF is inferior, 2 is inferior, and 1 is lateral. So there's signs of ischemia sort of everywhere, laterally, inferior, and on the right side. Which lead would read the activity of the left ventricle the best? And that would likely be leads V5 or V6, since they are located more near the apex of the left ventricle. Now that we know what an ECG measures and what the lead placement represents, how it affects QRS morphology, let's get into putting it all together. We're going to learn a 5-step method for reading and interpreting ECGs. Rate, rhythm, axis, hypertrophy, and ischemia. The goal is not necessarily to be able to interpret everything, but to be objectively able to identify specific parts of an ECG, and later we can put it all together. The first step of reading an ECG is determining the heart rate, and by that we mean the ventricular rate, which we know is represented by the Qrs complex, which is ventricular depolarization. We're determining the rate to determine if it's a tachycardia, bradycardia, or a normal heart rate. Tachycardia would be defined as greater than 100 beats per minute, normal 60 to 100, and bradycardia less than 60. There's two main methods for determining ventricular rate. The first would be the Qrs method, where you calculate the number of QRSs that occur in 10 big boxes and multiply it by 30. Remember, each big box is 0.2 seconds, or 200 milliseconds, so 10 of them is 2 seconds. And if you count the number of QRSs within 2 seconds to find out how many QRSs occur in 60 seconds, you would need to multiply by 30. So here we have 10 big boxes. You can count 1, 2, 3, 4, 5 ventricular depolarizations. 5 times 30 is 150 beats per minute. This would be a tachyarrhythmia. Another method for calculating the heart rate is the box method. Find a QRS that lines up on a big box. Calculate or measure the number of big boxes between that and the next QRS. Take that number and divide 300 by it, and that will also give you your heart rate. This only works if the QRSs are occurring at regular intervals, meaning the distance between each QRS is the same each time. We'll talk about regular or irregular intervals in just a moment. But here you could see if there was only one box between these two QRSs, that would be a heart rate of 300. 2 boxes is 150, 3 is 100, 4 boxes is 75, and 5 would be a heart rate of 60. Here's a practice. Pause here and calculate the rate using whatever method you want. If we're using the Qrs method, here I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 boxes with 2 QRSs in it, and thus the heart rate appears to be 60 beats per minute, which is 2 times 30. Using the box method here, these don't line up exactly on a large box line, but if I shifted them both over to the right, it looks like they would pretty much line up. So let's just count 1, 2, 3, 4, 5, 6 boxes. So this would be somewhere, 300 divided by 6 would be 50 beats per minute. So this is somewhere between 50 and 60 beats per minute. Either way, a bradycardia. Over here, using my big box method, I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And I have 1, 2, 3, 4, 5 QRSs in those 10 big boxes. Thus, 5 times 30 is 150 beats per minute. Using my QRS complexes, using the boxes between them, here's a QRS that lines up right on, and we can count 1, 2 boxes in between. 300 divided by 2 is 150. The next step to interpreting ECGs is rhythm. This is where a lot of people can get hung up. But as long as you understand what each wave morphology and interval represents, it's easy to understand what aberrant waves or long intervals could represent. So there's a 3-step process for interpreting rhythms. 1 is identifying regularity. 2 is identifying what the intervals are to determine if any are long. And the third is evaluating the P and Qrs relationships, or the atrial and ventricular depolarizing relationships. The first step in assessing the rhythm of an ECG is assessing regularity. This is in reference to the distance between each QRS complex. In a regular rhythm, you'll have the same distance between each QRS. In an irregular rhythm, you'll see the QRS distance change from beat to beat. This is helpful for identifying certain arrhythmias, such as atrial fibrillation, which has irregularly spaced QRS complexes. The second step in rhythm interpretation is measuring your intervals. Remember, I want you to be able to objectively identify these things on an ECG. After we've identified all of the abnormalities, we'll synthesize what it means at the end. We're focusing on identifying these abnormalities. So, is your PR interval normal? Or is it prolonged, such as this PR, which is greater than 200 milliseconds? Is your QRS normal? Or is it prolonged, like this QRS, which is greater than 120 milliseconds? Is your QT interval normal? Or is it prolonged? A prolonged PR would represent a delay in atrial depolarization reaching the ventricles, usually an AV block. A prolonged QRS can represent many things, as we'll talk about shortly, but means there's something delaying ventricular depolarization. And a long QT means there's something delaying the entire cycle of either ventricular depolarization or, more than likely, ventricular repolarization. The final step in assessing rhythms is to assess the P and Qrs relationship. Remember, this is atrial depolarization with the P wave and ventricular depolarization with the QRS. In a normal heart, the atrial depolarizing stimulus leads to ventricular depolarization, so you should always have a P wave leading to a QRS. If that is not the case, something is abnormal. We're going to focus on identifying these abnormalities and not necessarily the meaning. We're going to explain that in the next few slides. But the first question we ask is, are there P waves? We're assessing, is there uniform atrial depolarization? If P waves are absent, as we'll learn in just a little bit, it might mean that the atria are not uniformly depolarizing, like occurs in atrial fibrillation, or it could mean that the P waves are masked by something like a tachycardia, where the QRSs are taking up all the real estate on the ECG. Next, we're going to ask, is there a P wave with each QRS? Meaning, for every ventricular depolarization, is it being caused by an atrial depolarization? Let's take an example down here. Here I have P, QRST, P, QRST, P, QRST, and suddenly QRS, 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 with no P waves preceding them. These are premature ventricular contractions, where the ventricles are prematurely contracting before atrial stimulus. We'll talk more about what can cause QRSs without Ps in just a little bit. The next question, is there a QRS for each P? Every time I have an atrial depolarization, is it being conducted to the ventricles? Or is there, say, a block where some of my atrial depolarizations are not conducted? Let's look at the example down here. I have a P wave without a QRS, a P wave without a QRS, with the QRS, a P wave without a P wave with, but now at a really long interval. So when you notice that you have extra P's or extra QRS's, it's a good idea to assess your P2p interval and your QRS to QRS interval. When I look at my P's, I can see that my P's are actually regularly spaced. So the atria are spontaneously depolarizing at a regular pace. And here is where a P wave would be, but it's masked by this QRS complex. Then I look at my QRS's, and these are regularly spaced. Yet the distance between my PQRS seems to change each time. What I'm noticing here is a full heart block, where the QRS's, or the ventricles, are spontaneously depolarizing at the same rate, and the atria are spontaneously depolarizing, but none of those signals are getting conducted to the ventricles. So the ventricles are going at their own rate. We'll talk more about what can cause these types of abnormalities, but I want you to focus on being able to identify that something is abnormal and documenting it, then figuring out what's going on. Let's do a practice. Let's practice objectively identifying abnormal morphologies on the ECG. Remember, the goal is to identify, and once we have all the pieces, later we can put it together. Our first question is, what is the rate? I can see here the QRS's are irregularly dispersed. This is an irregular rhythm, which means I need to use my 10-box method. Starting from the first ECG I see, and counting 10 boxes, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I count 1, 2, 3, 4, 5, 6 QRS's in that 10-box 2-second interval. So 6 times 30 is a heart rate of 180. This is an irregular, fast rhythm. Next, I need to check my intervals. First, what is the PR interval? Well, unfortunately, I don't see any clear P waves representing synchronous atrial depolarization. There's a lot of electrical activity going on here, but the morphology of these P waves seems to be different, and it actually looks more like fibrillating atria as opposed to any clear synchronous atrial depolarization. So without active P waves, there is really no PR interval, and that's the first thing that we can identify. Absent P waves and no PR interval. Next, let's check the QRS complex. This appears to be narrow, approximately 40 milliseconds, but way less than 120, so this is okay. Finally, the T wave does not appear to be present, as it's likely masked by whatever electrical activity is occurring in the atria with this strange fibrillating electrical activity that's occurring between each QRS complex. So I can't assess the QT interval on this lead. You could potentially look in another one if you needed to. However, the distance between each QRS is less than 400, and we know a normal QT would be under 400, so this appears okay. Although some of these irregular ones, it appears to be prolonged, but we don't know where the T wave is within here. Next, we need to assess if the P waves are regular. However, there are no clear P waves to assess. These look far too small to be P waves, and there's way too many of them for this to be a successive A flutter. This would be something like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, atrial depolarizations before a QRS. So this seems like fibrillation. And is there a P with each QRS? Nope. And is there a QRS with each P? Absolutely not. So it appears like we detected absent synchronous atrial depolarization. The QRS's are still depolarizing. The ventricles are still depolarizing, and they're probably doing so from at least above the bundle of His, because we're seeing these narrow QRS's, as you'll see when we talk about causes of long QRS's. So the goal here was just to identify abnormalities. We see absent P waves, we see irregular rhythm, and we see tachycardia, which, as we might learn later, is sort of pathognomic for atrial fibrillation. Now that we're used to identifying abnormalities, let's find out what some of the reasons are for these abnormalities to occur. When P waves are absent, it means the atria are not depolarizing in a synchronous manner. This can happen when you have electrical depolarization circulating throughout the atria in every which direction, also known as fibrillating atria, and that is AFib. The textbook definition of AFib would be absent P waves and irregular QRSs, as the ventricles will beat whenever the AV node accepts a depolarizing stimulus from the atria. And this, since the atria are fibrillating, they're going at a rate of about 700 beats per minute, meaning there's always a stimulus to depolarize the ventricle. Thus, the ventricular rate becomes dependent on the refractoriness of the AV node, which can change from beat to beat and be irregular. Another reason to not have P waves would be for them to be masked by Qrs complexes in, say, a tachycardia. This is supraventricular tachycardia down here, where the heart rate is going so fast that QRSs overtake any visible P waves that are occurring. Now let's talk about what it means to have a long PR interval or have multiple P waves, aka atrial depolarizations, without ventricular depolarization or QRS after it. We classify these as heart blocks. A first-degree heart block is when you have a long PR interval, greater than 200 milliseconds, meaning that your atria depolarize and for some reason your ventricles are taking a while to begin depolarizing after that. A second-degree heart block is when you have some non-conducted atrial depolarizations, and a third-degree heart block is when you have full AV nodal dissociation, meaning no atrial depolarization is getting through and the ventricles are spontaneously depolarizing completely on their own. We'll walk through an example of each one. This is an example of first-degree heart block. We have a long PR interval between each of our QRS complexes. And this just represents some form of conduction delay between atrial depolarization and ventricular depolarization. It's frequently caused by medications, such as beta blockers or calcium channel blockers, anything that can block or slow the AV node. Sometimes it's caused by excessive vagal tone, meaning too much acetylcholine from the vagus nerve is being sprinkled onto the AV node and causing a bradycardia with a long PR interval. Second-degree heart block is characterized into two types. We have Mobitz 1, or Winke-Bach, and then Mobitz 2. Mobitz 1 is when you have a prolonging PR interval until eventually the depolarization of the ventricles never occurs. So here's Mobitz 1. Our PR is normal, our PR prolongs even further, and then we have a non-conducted beat, and we restart. This is pretty characteristic of certain types of myocardial infarctions. A Mobitz 2 is when we have a regular PR interval, but we simply drop a beat right here, but resume with a regular PR interval. Either way, both of these are types of second-degree heart block. Other ways to characterize these heart blocks are via how many P waves are conducted before a QRS. Here's a 2-to-1 heart block, meaning I have a P wave with a QRS, then I have a P wave without, a second P wave with a QRS, P wave without, second with a QRS, meaning for every 2 P waves, I get 1 QRS. This is a 2-to-1 heart block and is considered second degree because the QRSs are still occurring after an atrial signal to depolarize. Next, we have third-degree heart block. This is where the atria and ventricles are not talking to each other. The ventricles are depolarizing independent of the atria via their own pacemaker. Remember, you need to use the bundle of His to go down both rows of the Purkinje fibers at the same time. If you're not doing that, you can't get synchronous ventricular depolarization, which leads to widening of your QRS. We're going to talk more about that in just a minute. But you can frequently see wide QRS ventricular depolarizations in a third-degree heart block because the ectopic pacemaker that's pacing the ventricles is below the bundle of His. You see the P waves. This is atrial depolarization going at a regular rate, and the QRSs are going at a rate regular to themselves, albeit very slow. But you can also have narrow QRSs in third-degree heart block, and that is if the pacemaker is coming from, say, below the AV node, such as at the bundle of His, you would have a narrow QRS. Another more unique reason to have P waves not conducted would be atrial flutter. Here you can see I have 1, 2, 3, 4 P waves conducted before a QRS. And here 1, 2, 3. So this would be 4 to 1 and 3 to 1 AV block. The problem is the atria are depolarizing so rapidly that the AV node is still refractory when it's receiving 1, 2, and 3 signals to depolarize. Finally, the AV node is repolarized and a P wave can send a ventricular depolarization. This is unique because it's generally a tachycardia. As you can see, I'm depolarizing at a rate greater than 300 beats per minute if you use our one-box method for my P waves. So sometimes you'll see atrial flutter occur, and because the atria are synchronously depolarizing so quickly, the ventricles cannot accept the depolarization because the AV node is refractory. Next, we're going to talk about things that can make a QRS appear wide. Here, I have a normal ECG. The sinoatrial node depolarizes and sends a depolarizing stimulus through the atria. When the atria depolarize, ions moving through those membranes, aka current, generates a force that deflects and creates my P wave. Then that depolarizing force reaches the AV node. Once it reaches the AV node, it moves down to the bundle of His and spreads simultaneously through the Purkinje fibers in the heart, leading to simultaneous depolarization of both ventricles. The simultaneous depolarization gives me a fast upstroke, and since they are both depolarized at the same time, it quickly falls back down to the isoelectric point. Then I get repolarization, and that leads to my T wave. So the synchronous ventricular depolarization from the Purkinje fibers allows fast, rapid ventricular depolarization, leading to a normal QRS of less than 120 milliseconds. A long QRS, greater than 120 milliseconds, means it is taking longer to depolarize the ventricles. There can be a lot of reasons why that would occur. Remember, normal depolarization is sinoatrial node to AV to my His-Purkinje system. If I happen to have depolarization occurring elsewhere, it can lead to problems with using the His-Purkinje system to get synchronous depolarization. Here's an example of an ectopic pacemaker occurring in the ventricle. I get depolarization stemming from that pacemaker and spreading outward, leading to partial depolarization of one ventricle. Eventually, that signal will find itself on the other side via retrograde conduction through the Purkinje fibers, and I'll get right ventricular depolarization. But because this takes longer to travel through the full length of these Purkinjes, as opposed to starting in the AV node and going down both at the same time, I get a prolonged QRS complex. This is why ectopic ventricular pacemakers create very large, wide QRSs. If I have a single pacemaker repeatedly sending the stimulus through the ventricles, I get a monomorphic QRS, since the depolarization looks the same each time in the same lead. And when this is occurring at a rate greater than 100 beats per minute, I get monomorphic ventricular tachycardia. Now, if I have multiple ventricular pacemakers firing off waveforms, depolarizations will look different depending on which one of the pacemakers happens to be the dominant one firing. So in a single lead, I will pick up different depolarizing waveforms when it switches to a different pacemaker. This is called polymorphic ventricular tachycardia and is very fatal. Now a quick review on our pacemakers. Remember, the dominant pacemaker of the heart is whichever one is going the fastest. In the human body, that's normally the sinoatrial node, which beats at about 80 to 100 beats per minute. But if the sinoatrial node were to die, the AV node takes over, and the heart gets an inherent heart rate of 40 to 60 beats per minute. This is likely an evolutionary survival advantage, that we have multiple pacemakers that allow our heart to continue pumping if one of the other pacemaker systems fails. If the AV node fails, then the Purkinje fibers, which are automatic tissue, take over. In the setting of a third-degree heart block, where the AV node is not conducting any of the signal sent from the sinoatrial node, we generally wind up with wide Qrs complex rhythm because the Purkinje fibers are taking over. As long as the ectopic pacemaker is initiating somewhere below the bundle of His, where the Purkinje fibers split, you'll end up with a wide complex rhythm because you're not able to send the signal simultaneously through both of the Purkinje fibers. And that's why we get these interesting wide rhythms for certain third-degree heart blocks. Not all third-degree heart blocks will have a wide QRS. If the new pacemaker pacing the ventricles due to absence of atrial stimulus starts somewhere above the bundle of His where the Purkinje fibers split, the stimulus will still move down both of the Purkinje fibers at the same time, leading to a nice synchronous ventricular depolarization and a narrow QRS. Another reason why we can have a wide QRS is that the atria do send a depolarizing signal to the ventricles, but one of the Purkinje fibers is sick and doesn't conduct the signal very fast, while the other one does. So you get rapid depolarization of one side, leading to your upstroke of your QRS, and then a slower depolarization of the other, keeping your electrode positively deflected for longer. A characteristic bundle branch block morphology is this dual peak morphology that occurs from one side depolarizing and then the next at a slower pace. We look for these morphologies. For a right bundle branch block, we'll look in our right leads, which would be V1, V2, and V3. And here's a classic bundle branch block on the right lead, V1. You can also see these as left bundle branch blocks, which have this characteristic dual peak, and you're going to look for those in your left-sided leads. Lead 1, AVL, V4, V5, and V6. Finally, the last reason, or one of the last reasons, to have a long QRS is delaying the current that moves through the ventricles. Remember, cardiac depolarization occurs when sodium channels open up and sodium floods into the ventricular myocyte. However, if you were to block one of those sodium channels, you could cause some problems. Here you see the quick upstroke of sodium entering into a cardiac cell, leading to full ventricular depolarization. You then detect the quick QRS upstroke, and it falls back to the isoelectrode point quickly. If you delay the time it takes for sodium to fully depolarize the cell, you'll delay the time to reach your peak amplitude of depolarization throughout the ventricles and prolong the time it takes to create your QRS complex on your ECG. And thus, you'll get a widened QRS from this decreased slope of sodium current. So in summary, things that make the QRS wide are things that cause longer time of depolarization of the ventricles, whether this is through non-synchronous ventricular depolarization or from sodium channel blockade leading to a delayed sodium current depolarizing them. Common causes are ectopic pacemakers in the ventricles, leading to a non-synchronous use of the Purkinje fibers. Other causes are bundle branch blocks, where one bundle that depolarizes a certain ventricle is moving a little bit slower than the others. And another would be sodium channel blockade, a common effect of many drugs. Now that we understand what can cause these strange morphologies or prolongation of our intervals, let's try to objectively identify abnormalities and reason out what could be causing them. Here's an ECG. Pause the video here and walk through the steps we normally would. When you're done, we'll go through the answers. The first question is, what is the rate? This is a regular rhythm, and if I look at this QRS and this QRS, I see 3 boxes in between, which means the heart rate is 300 divided by 3, or roughly 100. The QRS appears regular or narrow, and if I look in lead 2, I can see that the PR interval also appears to be less than 200. It appears that I have a P with each QRS when I look through, and I don't see any extra QRSs without Ps. It can be hard to know which lead to look in. I recommend finding one lead with a clear PQRST morphology and assessing that one to identify if there are Ps with each QRS. The QT interval also appears to be under 400, but the QTC would be calculated by our computer. The P waves are regular and the QRSs look regular. Nothing too concerning. This appears to be normal sinus rhythm, so nothing to worry about. We identified no abnormalities. Here's another practice. Look at this ECG. Use our rhythm and rate methodology to assess for abnormalities, and then we'll try to synthesize if there's any reason why this is occurring. Pause now, and when you restart, I'll go over the answers. What is the rate? This appears to be regularly dispersed, so we can use our box method. Let's look for a QRS that starts on one of the big boxes, such as this one. I count 1, 2, 3, roughly 4 boxes in between each QRS. 300 divided by 4 is 75, so this is a normal heart rate. It appears to be regularly dispersed. Next, we need to assess our intervals. Here in lead 2, it looks like I can see P waves. So P, and here's my R. This is less than one large box, so the PR interval is normal. My QRS appears to be wide, and it appears wide in almost every single lead. So that is abnormal, but let's continue to assess. PQRS, 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 PQRS. It looks like there's a P with each QRS and no extra QRSs without Ps. So the atria are depolarized in the ventricles, from what is apparent. The P waves appear regular, dispersed, and so do the QRSs. So why do we have a long QRS? Potentially from ectopic pacemakers, sodium channel blockade, or bundle branch blocks. However, when we look in the right and left leads, it's long in all of them. So it's unlikely this is any form of bundle branch block. I don't think it's an ectopic pacemaker, since the P waves seem to be leading to depolarization of the ventricles. So this might be explained by sodium channel blockade, and a good review of the patient's medications or potentially ingested toxins could help us figure that out. Now, what is confusing about this ECG is the T waves appear inverted, and I know that we haven't gone over that yet, but this is something that could represent ischemia or potentially hypertrophy. Here is a summary of what various abnormalities on an ECG might represent, and it's not all-inclusive. Rhythm is one of the hardest parts for most people to understand, but focus on understanding what the waves represent and being able to objectively identify abnormalities, and then, using your knowledge of physiology and the conduction system, postulate potential reasons for those abnormalities to occur. We're now going to move on to a concept called axis, or determining the overall net force of conduction of the heart. Remember in the beginning of the lecture, we said if you're driving 60 miles an hour to the west and firing a soccer ball 60 miles an hour east, the ball will drop straight down. That's because the net total force of something is equal to all the forces acting together. So force of A plus B plus C. When we look at the heart, you have forces depolarizing leftward, rightward, upward, but overall, the largest part of the heart is the left ventricle. And since this generates the most force, the net total force detected from electrical depolarization should be downward and to the left. So, to assess cardiac access, we know that leads that are placed laterally and inferiorly should both get a positive deflection from the downward to the left depolarization of the heart. So to check the access, we check to see that the lead is upright in our lateral lead and our inferior lead. So here's lead 1, and I see that it's upright, and that is great. And here's lead AVF, which is also upright. So this means the net force of depolarization of the heart is downward and to the left. Now, sometimes we can deviate from this axis. One example of this is left axis deviation, where it appears that the total depolarizing net force of the heart is actually upward and to the left. When we look at this, we should be upright in our lateral leads, such as lead 1, but will actually be negative in our inferior leads because the force is moving away from the inferior leads. Causes of left axis deviation include left ventricular hypertrophy, where if you have a very enlarged left ventricle, it can pull the overall force upward, or potential right-sided or inferior myocardial infarction. Remember, dead tissue will not conduct electricity, so you're going to see an overall change in your force moving instead of downward and to the left, you'll see upward and to the left. Another type of deviation is right axis deviation. This is where we're no longer moving leftward with our total force. So the net sum force is downward and to the right. In this case, we're going to be upside down in our lateral leads, such as 1 and AVL, and we're going to be right side up in our inferior leads because the net force is still moving downward. Causes of right axis deviation include right ventricular hypertrophy, so a very large right heart now able to generate a lot of current, or a left-sided myocardial infarction. So I'm no longer producing much current on the left, and thus the right side predominates. Another cause is dextrocardia, where the heart is actually inverted and your largest ventricle is on the right side. A very extreme form of axis deviation is extreme right axis deviation. You will be downward in your lateral and in your inferior leads because the net total force is moving upward and to the right. Causes of extreme right axis deviation can include retrograde conduction, where the force begins in the left ventricle and moves backwards up to the left atria, and we get a net depolarizing force of upward and to the right. Certain myocardial infarctions can cause this, and the most common cause in a normal healthy person would be reversed limb leads. Here's a quick summary of all of the axis deviations that can occur, as well as the normal axis. You can check leads 1 and lead AVF, and depending on the overall positivity or negativity of these leads, determine the axis and potential health problems that go along with it. Here's a practice. Assess the axis of this ECG. Pause now, and when you're done, resume, and we'll go over the answer. This appears to be left axis deviation. You can see that we're upright in leads 1 and leads AVL, meaning the force is moving in total to the left. But we're downward in leads 3 and AVF, although it's very hard to assess. This would mean that the force is moving upward overall. So we're now moving upward and to the left. One potential cause of this would be left ventricular hypertrophy, or potentially an old right-sided myocardial infarction, or a new one. Here's another practice. Pause, assess the axis, and when you're done, click resume. This appears to be right axis deviation. I'm upside down in my lateral leads, such as 1 and AVL, but upright in AVF, 2, and 3. This could potentially be caused by right-sided hypertrophy or potentially dextrocardia. Now we're going to learn how to assess for hypertrophy on an ECG. Remember, the larger the heart is, the more muscle there is. The more muscle, the more ions that move through it, and thus the larger the current. And the larger the current, the larger the deflection on your ECG. So we can look for very large waveforms in certain spots to represent cardiac hypertrophy from excessive current. Here, we can look for left ventricular hypertrophy on leads that actually assess the left ventricle. So you can look for enlargement of left-sided leads like V6, 1, and AVL. To assess for left ventricular hypertrophy, there's something called the voltage criteria. There's a lot of different ones. I'm only going to have you remember this. The largest R wave in any of your precordial leads plus the largest S wave, these are your chest leads, if they equal greater than 45 milliliters, which would be 9 boxes, that's voltage criteria for left ventricular hypertrophy. Another one to remember is that if the R wave in V6 plus the S wave in V2 is greater than 7 boxes, that's also voltage criteria for LVH. Let's look here. Here, this is V5, which means that this here is V2, and this is V5. When I look at the S wave in V2, it appears to be 1, 2, 3, 4, 5, 6, 7 boxes deep. If I add that to the R wave in V6, which is at least 1, 2, 3, 4, that's 11 boxes, meaning this patient likely has left ventricular hypertrophy. Other signs of hypertrophy that you can see are deep inverted T waves in V3 through V6, sort of like this. T wave inversion can also be a sign of ischemia. However, when it's these deep inverted ones, it's more likely hypertrophy. Ischemic T waves look like a regular T wave that's just flipped upside down. You may also see things like ST elevation in the right precordial leads, which is kind of reciprocal to these deep inverted T waves, and ST segment depression and T wave inversion in the left-sided leads, which is a left ventricular strain pattern. I want you to just focus on remembering these. You can also see some signs of atrial enlargement. These are some of the morphologies you might see in right or left atrial enlargement. We check in lead 2 and V1. Remember, V1 is most closely related to the right atria, so it's a good one to look in. Feel free to familiarize yourself with some of these morphologies. Finally, we need to look in each lead of the ECG for ischemia. Signs of ischemia include pathologic Q waves, ST segment depression, ST segment elevation, T wave inversion, and potentially new bundle branch blocks, depending on if they meet other criteria, like being hypotensive or meeting something called the Smith-modified Scarbosa criteria. We're not going to go too much into bundle branch blocks. We're just going to focus on Q waves, ST segment depression, elevation, and T wave inversion. Finally, we get to talk about the Q wave. You've heard about Qrs complexes your whole life, yet half of the ECGs we looked at didn't have a Q wave. So why do we keep talking about it? Well, the Q wave normally represents septal depolarization, and it is present in some leads. Here we have the SA node. It would depolarize, go to the AV, and then move down the AV node to the bundle of His and split off into the Purkinje fibers. In the Purkinje fibers, the depolarizing force splits off to the right. So this is actually a left to right depolarization, which briefly generates a net rightward force before the ventricles depolarize. Thus, my leads on the left side of the heart will measure that as a negative deflection. So it's frequently common to see Q waves in 1, V5, and V6, and they're generally less than a millimeter. They generally never exist in V1 to V3, so if you see them there, it may represent a pathologic condition. Now also remember, because 3 and AVR are detecting force moving leftward as negative, you can see Q waves in 3 and AVR. That's just the representation of our normal leftward force, and you should generally ignore any Q waves in 3 and AVR. A pathologic Q wave represents dead tissue that's unable to counteract the depolarizing force of its opposite tissue moving in the other direction. Pathologic Q waves are any Q waves in V1 through V3, or a Q wave in 2 continuous leads that's greater than 2 small boxes or greater than 25% of the height of the R wave in that ECG. Here's a great example of a pathologic Q wave in lead 1. Normally, the left side of the heart would be larger, and the overall net force would either be equal when you consider the right side of the heart depolarizing at the same time, or it would actually probably be moving towards lead 1. But in this case, we have an area of necrosis producing no force. So lead 1 detects only the depolarizing force of the right atria or the septum moving left to right. And thus, we get a downward deflection and then finally come back up for our QRS. Next, we're going to talk about ST segment depression. I'm going to explain why this actually occurs. ST segment depression represents partial wall thickness ischemia, meaning it's bad, it's ischemia, but there is still part of the heart that is alive in that area. So let's review why that is. Firstly, remember that cells sit at a resting membrane potential of about negative 90 millivolts. If I have an area of partial wall ischemia, the cells there are dead, as you can see. Those dead cells are leaking potassium, and the increase in extracellular fluid potassium around the surrounding cells is actually raising the resting membrane potential of the surrounding cells, because the intracellular potassium has less of a gradient to want to leave the cell. Thus, there's more positive charges within the living cells. Less potassium leaving means more intracellular K, and thus the resting membrane potential is raised. And the cells surrounding these dead cells are in a constant state of partial depolarization because of the raised resting membrane potential. This is a current that can be detected, and that current is moving towards our lead. Thus, at baseline, due to the partial repolarization of those cells, depolarization, we get a positive deflection of our lead at baseline. This raises the isoelectric point of our lead during the PR interval. Then, when depolarization occurs, all of our cells depolarize at once, resetting the isoelectric point back to 0. And the remainder of the ECG is conducted at our true isoelectric point, which is lower than when we were having some baseline deflection occur. And this is why the ST segment appears depressed relative to the PR interval, which was raised due to the constant partial depolarization of cells surrounding the dead tissue from a raised resting membrane potential due to higher extracellular potassium concentrations, reducing the gradient for potassium to leave the cell. We can have ST segment depression that appears to be upsloping, downsloping, or it might be completely horizontal, but you can see the different morphologies here. Now, ST segment elevation is a more severe sign, and it represents full thickness ischemia. Please ignore this partial there. Now, here was the little image that we had on the last slide. Remember, some of the cells died, and then these cells in this area were partially depolarizing, sending a signal to this lead to raise the isoelectric point. Well, in a full transmural ischemia, all these cells are dead, and thus the cells surrounding it are undergoing the same thing, where there's higher ECF potassium, preventing intracellular potassium from leaving, raising intracellular positively charged ions by reducing efflux, raising my resting membrane potential, which leads to partial depolarization. But this time, since all the cells are dead, there is no depolarizing force moving towards the lead. It's all moving away from this lead. And thus, it lowers the isoelectric point at baseline. Then, when you get a full depolarization, all cells fully depolarize. It resets the isoelectric point back to 0, and the rest of the interval is conducted at the new isoelectric point, which is why the ST segment appears elevated relative to the PR segment, which was depressed. You don't have to know why these things occur, but I think it's valuable to remember, so that's why we went through them. The key is to be able to identify ST segment depression and elevation. ST segment elevation has some criteria around it. It must be present in 2 consecutive leads, and it depends on how old you are and your sex as to whether it qualifies. Greater than 1 millimeter is qualification for ST segment elevation in most leads, but in V2 and V3, it needs to be a little bit larger. So if you are over the age of 40 and a male, you need a 2 millimeter elevation in lead 2 and lead 3. If you're under the age of 40 and a male, it needs to be 2.5 millimeters. And if you're a female, it needs to be greater than 1.5 millimeters. In all other leads, if you have greater than 1 millimeter elevation in 2 consecutive leads, that is criteria for ST segment elevation, meaning you have a serious full thickness MI going on. Other signs of ischemia would be T-wave inversion, and as we talked about when talking about hypertrophy, ischemic T-wave inversion appears more to be simply a T-wave flipped upside down, as opposed to the more deep pattern you can see with hypertrophy. All right, let's practice. Pause here and search through the leads for signs of ischemia. When you're done, click resume, and we'll talk about where they are. So when we look in the various leads, we can see here in lead 3, we have ST segment depression, and as well as in AVF. In lead 2, I also have significant depression. And in lead 1, I might have some T-wave inversion. In AVR, I have nothing all that significant. In AVL, potentially T-wave inversion. And then that looks like about it. So this would be potential 2, 3, and AVF ST segment depression could represent an inferior wall, non-full thickness myocardial infarction, or the vessels supplying the inferior wall with blood might be having a blockage and thus need catheterization. Let's practice again. Pause, assess each lead, and try to identify where the ischemia is occurring. When you're done, click resume. So it appears we have ST segment depression in 3 and AVF. We have a Q wave in AVL, and we know that it's normal to see those, but if they're greater than 25% of the R wave, it might be indicative of some form of ischemia. We also can see bundle branch morphology in V1, so there's potentially a right bundle branch block. And we have ST segment depression in V5 and V6. So potential inferior lateral MI, something that we should probably be concerned about. I know we went through a lot. Here's a summary, discussing the tracing and what they measure, the different morphologies of our PQRST complex, the lead placements and what they look at in the heart, and of course our method: rate, rhythm, axis, hypertrophy, and ischemia. Now that we've done each piece individually, we're going to go through some full practices. Go ahead and pause when you see the ECG, run through your rate, rhythm, axis, hypertrophy, and ischemia, and report out the objective findings that you're seeing. And I will follow along with you. Pause now and read the ECG. This ECG appears to be regularly dispersed in terms of QRSs, has a heart rate of approximately 100, seeing as between these two QRSs I have 1, 2, 3 boxes. So 300 divided by 3 is 100. In terms of rhythm, it looks like I have good P-QRS morphology, and I appear to see a P with every QRS, or P with every R, and no additional RS waves without a P. My P to R interval appears normal, less than 200, and my QRS is less than 120. My QT interval appears less than 400, although I would need the computer to do a QTC calculation for me. My axis, I appear upright in lead 1, and I appear upright in AVF. Thus, this looks like normal axis. Hypertrophy, if I count the S wave in V2, 1, 2, 3, 4, 4.8, and the R wave in V5, I see 1, 2, 3, 4, 5. This appears to meet criteria for left ventricular hypertrophy, seeing as I have greater than 7 boxes between V2 and V5. In terms of ischemia, it does appear that I may have some ST segment depression in 3 and AVF, as well as V6 and V5, which could be related to hypertrophy or ischemia, in which case this would be inferior lateral ischemia. I also have ST segment depression, or T wave inversion in lead 1, but these are those deep inverted waves that are frequently seen with hypertrophy. This might be something you would need to compare a prior ECG to. I also see some ST segment depression in V4 and V5. So, potential ischemia and left ventricular hypertrophy with normal sinus rhythm and normal axis is how I would interpret this ECG. Let's go to the next one. Pause now, and when you're done, let's interpret. This appears to be a regularly dispersed QRS complex, and I have 1, 2, 3, 4 boxes between 2 QRSs. 300 divided by 4 is 75, so this is a normal heart rate. In terms of my rhythm, it appears that I have a P with each QRS for as many as I can see, and no extra QRS complexes. It appears that my PR interval is normal and my QRS is narrow. For my axis, I'm upright in AVF and in 1, so it appears this is normal axis. I don't see any signs of left ventricular hypertrophy. P waves look normal morphology, and I see no ST segment elevation, depression, T wave inversion, or pathologic Q waves. This appears to be normal sinus rhythm without any hypertrophy, ischemia, or axis deviation. Same here. Pause now, interpret the ECG, and we will interpret it after. This appears to be an irregular rhythm, so we'll use our 10-box method. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And I've got 1, 2, 3, 4 QRSs within then, which is 4 times 30 is 120 beats per minute. In terms of the rhythm, I have no clearly identifiable P waves in any of the leads, so my P waves appear absent. My QRS complex, hard to tell because I can't zoom in, but I think it is narrow, or less than 120 milliseconds. My T waves are also not super clear. I'm checking each lead to find one. It looks like in V2 I have some clear T waves. So here's my R, and my T is less than 400 since it's less than 2 boxes. In terms of hypertrophy, I definitely have some long S waves in V1. Almost hard to count because my S waves crash into my R waves here, but 1, 2, 3, 4, potentially 4, and my R waves are too small in any V4 through V6 to meet voltage criteria for left ventricular hypertrophy. From ischemia, it looks like I might have T wave inversion in lead 3, although it's very hard to tell, and I do appear to have some ST segment depression in V2 and V3. So you might say that this is an irregular rhythm with absent P waves, which would be indicative of atrial fibrillation. It's with tachycardia, so this is probably AFib with RVR and apparent potential right ventricular RV septal ischemia occurring. And I forgot one last thing. We didn't check axis, but we're upright in 1 and AVF, so it looks like this is a normal axis rhythm. Okay, same thing. Let's read the ECG and come back when we think we know what's going on. Okay, it appears to be a regularly dispersed Qrs complex, so we're okay to use our box method for calculating the rate. Here's a Qrs that lines up right on a box. So I have 1, 2, 3, 4. So somewhere between 3 and 4 boxes between my next Qrs. So this is somewhere between 100 and 75 beats per minute, which would be normal. Assessing my rhythm, it's regular, and I have a P, QRST, P, QRST, P, QRST. It looks like there's a P with every QRS. I don't see any extra QRSs without a P and no Ps without a QRS. My intervals, PR is normal. It looks like my QRS is narrow. I see no signs of hypertrophy in terms of prolonged S waves or excessively heightened R waves in the left leads. And for ischemia, I think we have some problems. Here I have ST segment elevation potentially in AVF, none in V2 and V3. In V3 I have very significant ST segment elevation, and I have continuous ST segment elevation in V4 and V5 and V6, and over here in lead 1. So this appears to be lateral, potentially inferior ischemia with normal sinus rhythm. We're also normal axis at AVF and 1 both being upright. Somebody call the cath lab. All right, that's the end of it. In 2 hours, you took those incomprehensible squiggles into valuable information about your patient and learned a new skill. So be proud of yourself. I can't wait for you to use this info to help your patient or teach somebody else about what they're looking at on the ECG. If you want more medical information or medical education, feel free to follow me on Twitter right below at empoisonpharmd, or check out my website, www.thepoisonlab.com, where I have a variety of free medical education, such as a podcast about poisoning, a free medical game where you can resuscitate different types of shock and use different vasopressors, and finally, other medical education videos. Thanks again for following. Have a great day.